So in this presentation, I'm going to give a bit of background about the Australian Institute of Health and Welfare. I'm going to make some general points about data and evidence. I'm going to talk particularly about data linkage at the AIHW. I'm going to make some comments about enduring data assets, enduring linked data assets that is. Also going to talk about some of the challenges about collecting data and analysing data under the COVID-19. And I'm going to present some findings and results from our new suicide and self-harm monitoring site. The Institute of Health and Welfare was created in 1987 under the Australian Institute of Health Act. Welfare added in 1992. We're an independent statutory body within the Commonwealth Health Portfolio, and we're primarily focused on bringing together state and territory data in a consistent form. So I often think about the Institute as being a creature of federation. We collate what are called national minimum data sets, where we bring together data consistently across jurisdictions. Not all federations have such a concept. So Canada, for example, doesn't have the equivalent of our national minimum data sets. But increasingly, we're playing a role in Commonwealth data, and the future of data in Australia is really about bringing together the state and territory with the Commonwealth data. The quotes I have on this slide just relate to the difference between administrative and survey data. A high proportion of the data held by the Institute is administrative data. Sometimes people say things like, well, administrative data isn't originally collected necessarily for statistical purposes. While that's true, administrative data is the whole basis for the statistical systems in the Scandinavian countries, so much so that Sweden hasn't run a census since 1990 because they don't need to, because there's so much data in their administrative registers. So the Institute mainly focuses on administrative data. If I compare the Scandinavian countries to the US has a much stronger focus on survey data relative to administrative data. Australia is probably somewhere between the two. The Institute is required under its Act to collate what we call flagship reports, Australia's health and Australia's welfare. We've moved more and more towards online reporting and interactive data use. And you can see that if you look at the website, particularly for Australia's health that we released earlier this year. So this slide just gives a visual presentation of Australia's health and Australia's welfare. And this slide shows the new format. We've got data snapshots, data insights, and in brief, the data snapshots are something we'll keep updated through the year. So Australia's health and Australia's welfare will become more of a living document rather than something that we just update every 2 years. This is just an example of one of the charts or slide in Tableau that we have on Australia's health. I thought this one was quite interesting when I was doing media for Australia's health because of just how large the decline in coronary heart disease mortality rates have been in Australia since the 1980s. To give a sense of that, in 1980 there were 10,121 deaths among people aged 55 to 74 for coronary heart disease. By 2018, that had fallen to 2,982, which is a massive decline when you consider the growth in the population over that time period. The actual mortality rate from cardiovascular disease has fallen for this age group by 87% over that time period. I mentioned that the Institute mostly relies on administrative data, but we do conduct a small number of surveys, including the National Drug Strategy Household Survey, and we released that earlier this year as well. On the positive news from that was that the daily smoking rate had actually declined again from 2016 to 19. The small decline from 2013 to 16 wasn't actually statistically significant, so it was actually positive news there. But one of the things this chart shows is how the decline in smoking in Australia over the period since 91 has overwhelmingly been driven not by ex-smokers who have given up smoking, but rather by a rise in the proportion of people who have never smoked in the first place. And that's particularly the case for young people. Smoking rates among young people are now extremely low. One thing you probably heard about is the replication crisis in quite a few areas of science, particularly around social psychology, nutrition science, but there's many other areas as well. And I guess when you read about the replication crisis and you think about that, it really does tell us one important thing, which is that data itself is absolutely critical, but how you analyse data and the care with which you do that is critical as well. data doesn't speak for itself. These are just two quotes relating to data and evaluation. I'll just go straight to the second one. Often people talk about outcomes from policies or programs, but really if all you do is observe the outcome, how do you know whether that program or policy actually affected that outcome? So as Rossi says, the challenge for evaluators is to assess not only the outcomes that actually obtain, but the degree to which any change in outcomes is attributable to the program itself. It's a very basic point, but it's so often forgotten. You often hear in public discussions about programs or policy, well, the program worked or the policy worked, why? Well, the outcomes improved, but that by itself doesn't necessarily mean that that had anything to do with the policy or program. Very basic point, but is so often not remembered. This slide, I've got a few quotes here, one by the PC. So when the PC looked at the education evidence base, it said that, look, there's quite a bit of data around. The gap isn't the data, it's the evaluation of policies, programs and practices. That's the key gap, not the data itself. We used to have the Closing the Gap clearinghouse at the Institute of Health and Welfare that we jointly looked after with the Australian Institute of Family Studies. One of the key findings from that was many areas of policy where the evidence around program or policy effectiveness was lacking. But that's not unique to Indigenous policy at all, and in fact it's not unique to Australia. It's worth also reading the draft Productivity Commission report on the Indigenous evaluation strategy. It makes similar points. Although it does make a good point, it gives an example of a policy that stopped because of good evaluation practices, which was the school enrolment attendance measure. So it's not always that programs or evaluations will lead to new programs or the continuation of programs. Sometimes it's good practice when they actually lead to program stopping. I also recommend a TEDx talk by Laura Arnold about the evidence base in the US, even where they've got a much stronger focus on randomised controlled trials. For example, in the US, there's still a lack of evidence in many policy areas. Start talking now about data linkage, where you're linking various data sets across each other. So data linkage is not a new thing in some ways. We've been undertaking data linkage projects at the Institute since 1990. All the proposals have to be approved by our ethics committee. That actually isn't a particular barrier at all. Getting the approval of the data custodians and actually getting the data is normally the thing that's the hardest. And the number of linkage projects we're undertaking continues to grow over time, and the linkages are becoming bigger and more complex. This slide just mentions the Population Health Research Network, of which this institute's a part. It's a group that cooperates on data linkage across the states and territories in the Commonwealth. This is an example of a linkage project, or a quite typical linkage project the AIHW gets involved in, particularly ones where we publish the data. This shows the association between young people under justice supervision and the use of alcohol and other drug treatment services. So it shows that young people under juvenile youth justice supervision are 30 times as likely as other young people to receive alcohol and other drug treatment services. If you focus on those young people who are on juvenile detention, the rate ratio is actually 35 times more likely than the population in general. And one thing to think about in terms of data linkage and looking at flows across data systems, a study in Victoria found that of young people sentenced to imprisonment by the Children's Court over a period of 8 months, 88% of those young children had been subject to a notification through the child protection system. So that, kids going through the child protection system, there's quite a high proportion of those kids and ending up in juvenile justice system. What that means is that, you can think about that and what assistance you can provide to try and avoid those sort of outcomes happening. But you only get that insight by linking data and looking at flows across data systems. The Institute's been undertaking data linkage since 1990, and one of the examples of that is to look at cancer survival rates. Cancer survival rates, of course, that data comes from data linkage, where you're linking mortality data with data from the cancer registries. So just on a positive note, the 5-year survival rates from all cancers combined for over that time period's grown from 50.5% in 87-91 to 69.2% by 2012-16. This is a similar slide for breast cancer for females, and over that time period, the 5-year survival rate has grown from 74.7% to 91.1%. Same data, but for bowel cancer, the increase in survival rates gone from 52.3% to 70.1%. This slide is for prostate cancer for males. 5-year survival rates have gone from 60% to 95.4%. I guess some of the take out of this data is that how in the past people would often see cancer as almost a very concerning thing to be told about, and it still is, but 5-year survival rates are very strong. Slightly less positive note, or considerably less positive note, to be honest. The survival rates for lung cancer, though, while they've improved, they haven't improved that much over that time period. For persons, the 5-year survival rates have only gone from 9.5% to 18.6%. One of the factors behind that is that lung cancer tends to be picked up quite late. As I mentioned before, sometimes you want to go beyond just the overall change in the outcome. You also want to know, did the policy or program have an effect on this? This is an example of a study the AIHW conducted that looked at the impact of breast screening, and it shows that women with breast cancers detected through Breast Screen Australia had a 42% lower risk of dying than women diagnosed with breast cancer who had never been screened. And in a sense, in this study where we had a control group, we weren't just looking at the overall outcomes. This slide shows similar sort of results for cervical cancers and cervical screening, and showing the impact of cervical screening on women and the positive effect that has. And this slide shows similar sorts of results for bowel screening programs. I'm going to move back on to data linkage now. So one of the interesting developments in data linkage, I think, has been a move towards the creation of enduring linked data assets, such as the NICI, which is listed here. So that's a real breakthrough, because in the past, linkage projects tended to be one-off and you'd destroy the data set after one linkage project was completed. The idea with enduring linked data sets is that you can use those data on an ongoing basis with still strict privacy controls and controls about access to data. But the NICI is another really good example where, and it's been created by the Institute with cooperation of the Commonwealth and the states and territories, where you're bringing together the state and territory and the Commonwealth data in a way that gives you a much better understanding of pathways and the service systems and how people move between those systems, and how that impacts on their outcomes, than you do by looking at the data in isolation. So in summary, the states and territories have great access to hospital data, but the Commonwealth has the MBS and the PBS data, and when you bring those data together, you get a much better picture of what's going on. So this slide just talks about another asset that we're working on, National Disability Data Asset. Be good to do something similar in the housing and homelessness space. But we're also doing joint work with the ABS on the juvenile justice and prisons data, because the AIHW holds longitudinal juvenile justice data, so we can follow people's pathways through the juvenile justice system. But the ABS holds the prisons data, but the ABS data to date hasn't been longitudinal or linkable. The idea is to help work with the ABS to get their data so that it is longitudinal linkable, and the ABS has made a lot of really good progress on that. And then we could at least look at pathways between juvenile justice and the prisons data itself, because we can't do that at the moment at a national level. This is a quote from the Auditor General in Western Australia, and in this audit she actually made the point that without linked data you can't actually really understand the service system and flows through the mental health system. So I've bolded part of the quote there. If the Mental Health Commission and WA Health use existing data in new ways to understand more about how people interact with existing services, they can develop targeted, more cost-effective care options. And for that audit, the Auditor General in WA actually did undertaking a linkage exercise where she linked across the WA mental health data. In responding to the report, the WA Department of Health made the point that the linkage would be even better if you could bring in together the Commonwealth data such as MBS and PBS data. Now talk a little bit about COVID-19. So this is a quote from Vladimir Lenin, and I think it's really apt at the moment. There are decades when nothing happens and there are weeks where decades happen. If you think about some of the dramatic changes we've seen in Australia this year as a result of COVID, particularly around the first lockdowns. Just to give one example, the number of people who were employed fell by nearly 610,000 in April and by a further 264,000 in May. The decline in employment in April was by far the biggest fall in employment in a month since the current labour force series commenced in February 78. The next largest fall was 75,000 in November 92. So these are really almost unprecedented changes in Australia's history in a very short time period. Now we've had a bit of a recovery in employment since then, but so much has changed since April and that lockdown that data for April alone, is so unrepresentative of what's happening now that it might as well be years ago. And that's very unusual that things are changing so quickly. This is a slide showing spending on alcohol from Commonwealth Bank cards. When interpreting this data, you've got a little bit of care because there has been a shift away from cash and to the use of cards over time, so that affects the data. But if you look at, this is an example of things changing so rapidly. So look at that week ending 27 March, and this is the change compared to the previous year. Look at that huge rise in the spending at bottle shops. Now that was partly to do with anticipation of lockdowns and people thinking that bottle shops might shut. But then you look at the sales at pubs and clubs and how that was down compared to last year considerably right up until June. It started to get a little bit, come back a bit in July. If you look at bottle shops over the year compared to previous year, they're up in all of those months apart from 17 April, it's only up a bit. But overall alcohol consumption based on the sales data isn't changed that much from last year, at least based on this data. We did work with the ANU to collect survey data on people's consumption of alcohol, and this survey was done in May. There were 20% of people said that their alcohol consumption had increased since the start of the pandemic. However, 27% said that it actually decreased. There was actually a gender difference though in both the ANU survey data and the ABS data, in that ABS Rapid Survey had questions on alcohol consumption. Females were more likely than males to say that their alcohol consumption had increased since COVID-19. Anyway, I've just showed this slide to show just how rapidly things can change at the moment. That big change in alcohol sales as a result, particularly pubs and clubs as a result of all of the various lockdowns. So one of the things that we were conscious of during COVID, particularly at the start of the year, was the need to collect timely data. I'm going to talk later about our work on suicide and self-harm, but there is a real need for survey data on people's level of psychological distress. So we partnered with the ANU Centre for Social Research and Methods because they've got the ANU Poll survey, which is based on the Life in Australia panel, which is a longitudinal panel, which is really important because it means you can do longitudinal analysis of the data. Also, the panel's representative. There has been quite a number of surveys conducted since COVID where people have been just invited, any member of the public been invited to provide answers, that sort of thing. Those sort of surveys can tell you about associations between variables, but it's hard to interpret those sort of surveys because they're probably not representative. Anyway, one of the things we wanted the ANU to focus on in the surveys was the level of psychological distress. And because they've got data pre-COVID, they've got a pre-COVID comparison point. So if you look at and this was based on the K6 measure of psychological distress, if you look at the level of the proportion of the population with severe psychological distress, that grew from 7.7% in February 2017 to 10.6% in April 2020. It fell down a bit to 9.7% in May. and it went back up to 10.1% in August. And there's variations in this by jurisdiction, so there's worsening in Victoria relative to the rest of the country since the onset of the recent lockdowns in Victoria. But this chart shows the pattern by age, has a very distinct pattern by age. The dotted line is the February 2017 results, and those solid lines are data from this year. And if you look at, say, 18 to 24, you can actually see that that's the group, and 25 to 34 and the 35 to 44 are the age group where psychological distress is considerably higher this year than it was in 2017. Whereas you look at the older age groups there, say 75 or more, or 65 to 74, and the dotted line's actually higher than the lines in 2020. So there's been a real difference in changes in psychological distress in the pandemic. Because the ANU work is based on longitudinal data, they were able to analyse that data and do regression on the factors that have led to changes in psychological distress. And it's very much associated, at least in part, with employment changes. That is, the biggest reductions of employment since the pandemic have been among young people, and that's at least in part explaining why young people are experiencing heightened levels of psychological distress. This is an example of a recent release where we've changed our reporting periodicity. We traditionally release homelessness service data once a year in an annual report, but we've started releasing monthly data. The key takeout from this data is that there hasn't been a pickup in the use of homeless services since the start of the pandemic this year. We released this report last week, and it looks at screening mammograms through Breast Screen Australia. And as you can see, we're comparing 2020 with 2018, and you can see a big drop off at the lockdown period because those services were temporarily suspended from 25 March. So there was more than 70,000 screening mammograms conducted in March. This had fallen to just over 1,100 in April. In April 2018, there was more than 74,000 conducted. However, on a positive note, we're starting to see the numbers come back in June, but they're still lower than they were in 2018. This slide from the same report shows the National Bowel Screening Program tests. We can't see a COVID pattern here. Remember, the bowel screening program test kits get sent to your home. The numbers are a bit lower in 2020 than they are in 2019, but that was evident prior to the lockdowns. So we can't see a particular effect from COVID on the bowel screening program. Showing this slide because increasingly we're looking at the association between education and various outcomes. This is a chart showing employment rates, that is the proportion of people in that age group who are employed. And this is for people who left school at 14 or below, equivalent to year 8. Now, there's not many people who have that level of education anymore. The vast bulk of people have high levels of education, of course. But the point of that chart is that back in 1976, even if you left school at 14 or below and you're a man, you pretty much had a job. That's much less the case now. So employment outcomes in particular are much more associated with levels of education than they were in the past. I'm now going to start talking about our suicide and self-harm monitoring work and site, which was launched a couple of weeks ago. This is one of the charts from the site. Now the site, along with many things on the AIHW website's got a lot of interactive data visualizations in Tableau. This one's quite an effective one because it provides the data right back to 1907. And it gives a very clear historical perspective. You can sort of see on the static image there the way that the data is interactive. On the actual website, you can choose different ways of presenting the data, etc. There's also a slider on that chart on the website that allows the period for the chart to change. But the bottom line from the chart is that male suicide rates, for example, are considerably lower than they have been over most of the last 110 years. The male suicide rate in Australia peaked in 1930, as you can see there. And the male suicide rate in Australia is now considerably lower than it was in the 60s. The female suicide rate peaked in the early 60s, and those high rates in the 60s were related to the unrestricted availability of barbiturate sedatives. When that was restricted, you saw reductions in the overall rates. So one of the things I was very keen to do with the new suicide site was to actually have data modelling undertaken to establish whether changes in the data were statistically significant or not. That can be quite tricky with data like deaths by suicide, because you can't use your standard normal distributions, because things like deaths by suicide, they don't follow a normal distribution. Anyway, commissioned the ANU to do a detailed study that's on the website, or the new website, and that shows that while the rates are higher than they were in 2007, which used 2007 because there was significant data improvements from then on, they rose nationally over that whole period and in New South Wales, Queensland and Western Australia, but were flat elsewhere. But the trends aren't uniform over that period. They were pretty steady from 2007 to 10. They rose from 2010 to 15, but there's no clear trend since 2005. 2015, they also found a seasonal effect in the data. Now, sometimes people think that because it's administrative data, you don't need to do things like test for significance of changes. It's not true, because you do get noise, including in administrative data. This slide again is from the new site, and it's for 2018, and it's based on a quite broad age category, because we've got that data right back to 1907. But as you can see, in 2018, the highest rates are for men in that 40 to 59 age bracket. Now, in this slide, it's the same data, but for 1930, which was the peak for the male suicide rate. Now, it's interesting to look at the age breakdown there. In 1930, it was actually males 60 plus who had the highest suicide rates. This is a slide showing deaths by suicide or suicide rates by the use of firearms, and you can see, a massive decline on a positive note since the 1980s and early 90s to now. Up until 1988, shooting by firearms was the main mechanism of cause of death for people dying by suicide for men. This is another cut of the data showing suicide rates by CEFA quintile. With CEFA quintiles, it's based on the socioeconomic status of the area. So the lowest quintile areas are those with the highest level of socioeconomic disadvantage. The highest quintile are those with the least. And as you can see, consistently, rates are higher in the lowest quintile. Also, the only quintile where you can see a clear trend is the lowest quintile, where there has been a pickup in suicide rates over that time period, but no clear trend in any of the other quintiles. This is a slide just showing age-specific suicide rates by age for males and females. There's a lot of focus on youth suicide, understandably, but the highest rates for men are those aged 45 to 49 and men aged 85 and above, although the number of men in that 85 and above group isn't high. Male rates are higher than female rates in all age groups. The highest female rates are among women aged 40 to 44. This slide shows intentional self-harm hospitalisation rates by age. Now, in the data, we can't separate out self-harm from actual suicide attempts, but there's a very big difference in the age structure. You can see that the highest rates of intentional self-harm hospitalisations are actually for girls aged 15 to 19. We've got some new data on the site on suicide attempts from ambulance data, and it shows a similar pattern, that the highest rates are among young women. It's not the middle-aged men in the same way for the actual deaths by suicide. One of the things we've been doing at the Institute since mid-April is we've been compiling data on the use of mental health services and data from the various crisis lines every week to inform and brief government. And we've also been receiving data from some of the suicide registers. One of the goals of our project on suicide and self-harm is to get suicide registers established in all jurisdictions. The advantage of the suicide registers is that you can get data on suspected suicides and numbers and trends, within days, whereas traditionally you're waiting years for the official data to be published. On our new site, we do provide some of the data that's available on deaths by suspected suicide since the onset of COVID, because there's been a lot of speculation about that COVID could lead to a rise in suicide rates. But on a positive note, the evidence from both Victoria and Queensland suggests that to date there has not been a pickup in suicide rates in Australia, and that's the same story in New Zealand, where the numbers are actually down in New Zealand compared to last year. And you know, the comments being made, particularly in New Zealand, that there's no inevitability to this. If people reach out and get services and help, there's no inevitability of an increase in suicide rates, and that should be the message. So what we're seeing in other data, which is a strong uptake in use of mental health services, is arguably a quite positive thing, because it means that people are reaching out to get help. But this is something we're going to continue to monitor as over time, every week. So the chart there, so if you look at the dark green line, you can see that the age standardised male suicide rate in Queensland until August 2020 is not that's dissimilar to in previous years, and there's a similar pattern for females as well. This slide shows new data that we're getting for the first time. We've got a partnership with Turning Point at Monash University, and they're actually coding ambulance data, including for suicide attempts. And this shows these data up until the end of June in Victoria for 2020, 2019, 2018. And again, you can't see any real change in 2020 compared to previous years. I mentioned earlier the association between education and various outcomes, and I've also talked about linkage. Now, this is new analysis on our site. We think this is the first time this has been done in Australia, looking at the association between cumulative risk of dying by suicide and level of education. This is an association that's been strongly shown in other OECD countries, and in particular I'd recommend, if anyone's particularly interested, Anne Case and Angus Dayton's book Deaths of Despair, which looks at different trends in particular by level of education in the United States, and similar data is published regularly in Sweden. So this is based on the ABS MADAP data, where there's been a link between the educational data on educational attainment from the census with mortality data. So what it shows is that there's a strong association between the risk of dying by suicide and education. Among males with a secondary or lower level of education, the cumulative suicide risk is 2.6 times higher than for males with a university degree. There is a relationship there for females as well, but it's not as strong, as you can see on the right-hand panel of that chart. This is a different cut of the same data, so rather than looking at the accumulated suicide risk, we're looking at the proportion of deaths by suicide that relate to people with different levels of education, and as you can see, the highest percentage is accounted for by people with a secondary or lower level of education. This chart, again based on MADAP linkage, shows the suicide risk by labour force status at the time of the census, and it shows a strong association. Interestingly though, if you look at men, the highest risk of dying by suicide is not among men who are unemployed, but men aged 25 to 54 who are not in the labour force. For that group, the risk is 3.2 times higher than for employed males. For employed males, the risk is 2.5 times higher than for unemployed males. The risk is 2.5 times higher for than employed males. And as I said, the risk is actually a bit higher for males not in the labour force than it is for males who are unemployed. If you look at females, not much difference between not in the labour force and unemployed, but there is a higher risk than for females who are actually employed. This is a cut of the same data, but we're now looking at proportions again. And this is an important distinction, because even though there is a heightened risk of dying by suicide for men and women not in the labour force and unemployed compared to the employed, if you look at males, for example, the majority of men who die by suicide were employed. If you look at females, again, employed is the biggest category, not in the labour force is second, and unemployed is is a smaller percentage. So I'm going to finish with this slide. This is just to show you that on our new site we have detailed data by level of geography. I'm not going to interact with this, it's just a static image of it. There's also a dashboard there on the top right hand corner on the website where you can go and interrogate the data more, and it shows the areas in Australia that they have the highest and lowest suicide rates. And there's other maps on the site as well. I've just got listed two books here that I particularly recommend. The first book by David Spiegelhalter, The Art of Statistics, Learning from Data. It's a real page turner to me. I found it a really, really great way of looking at data. It's quite a sophisticated book, but it does it in a very accessible way. And David Spiegelhalter has done a lot of good work since the onset of the pandemic on various podcasts and in his own writings. Second book, just read recently, Calling Bullshit, The Art of Skepticism in a Data-Driven World. I think that's a really interesting and good book as well to read. Some of the things that are good in that book are the way in which it talks about some of the hype with regard to data. There is a lot of potential with big data, for example, and things like machine learning. But the book makes the point that if the underlying data that a machine learning algorithm is applied to is poor or unrepresentative or flawed in some way, then the resulting analysis is also likely to be flawed. So just because data is big doesn't mean it's going to give you a particular insight. It can, but you really have to focus on data quality as well. It's not just a matter of how big the data is. And I mentioned before some of the surveys that have been conducted since the onset of COVID-19. You always have to have regard to things like, is the data representative? Is the data collected from a probability sample? And even administrative data that's based on a huge number of people, you've got to think, well, what does that data represent? Who's in that data? Who's not in that data? That sort of thing. So both of those books I'd recommend. So I've covered a range of different topics, but I've focused particularly on some of the work of the Institute, some of the challenges that have occurred under COVID-19. Happy to answer any questions.